At the other time, we established that the thyroid gland secretes what? The thyroid hormone. Okay. The thyroid gland secretes the thyroid hormone. And this thyroid hormone basically is being released to help with metabolism. Okay. It helps control metabolism. It also helps with the growth and development. So this is basically what we know about the thyroid hormone secreted by the thyroid gland. Okay. So when the thyroid gland does not secrete enough of the thyroid hormone, it means that there's going to be disturbance in metabolism or there's going to be slow metabolism. Okay. We established that in hyperthyroidism, the thyroid gland is secreting more of the thyroid hormone. So there's an increase, right? There's an increase in metabolism or metabolic rate. But here, because the thyroid gland is secreting less of the thyroid hormone, there's not going to be what? A reduction or a slow what? Metabolic rate. So let's not forget. So as we can all see on the screen, hypothyroidism is a condition where the thyroid gland does not produce enough of the thyroid hormones, and this leads to what? Metabolic disturbance. We have types of. Can we mute up? Okay, we have types of hypothyroidism. Okay, we have the primary hypothyroidism, the secondary hypothyroidism, and then the congenital hypothyroidism. Okay. So the primary hypothyroidism, this is when the thyroid gland is not functioning as it's supposed to. Okay. So that is primarily the issue is primarily in what? In the thyroid gland. The thyroid gland is not producing enough of the thyroid hormone as we all as it's supposed to do. Okay. The thyroid gland is not producing enough thyroid hormone as it's supposed to be. Then we get the primary what? The primary hypothyroidism. Okay, very good. Now the secondary is when the pituitary gland is not functioning. Okay, when we talk about the pituitary gland in endocrine system, what comes into our mind? Anytime we talk about pituitary gland in the endocrine system, what comes into our mind? Hello. Hello, class.
The master gland.
The master gland. Okay. Anytime we talk about pituitary gland, what comes to our mind is the master gland. So let's not forget. Okay. Let's not forget. Anytime you something is wrong in the pituitary gland, it is likely that the rest of the gland will be affected because the pituitary gland is the master gland. Okay. So anytime there's something wrong in the pituitary gland, likelihood that the other glands will be affected or dysfunction is very, very high. Okay. So that is why we have the secondary hypothyroidism. So in the secondary hypothyroidism, the issue is not really in the thyroid gland. Okay. But then the problem is in the pituitary gland. Being the master gland, there's a dysfunction over there. And this has caused a problem in the thyroid gland. Okay. So that is what caused the secondary hypothyroidism. Then you have the congenital hypothyroidism, which is also not a cretinism. You know, this one occurs or affects children. They are born, it's like they are born, and then their thyroid gland is not secreting enough of the thyroid hormone. Okay. So that is how the congenital hypothyroidism is or comes about. Okay. All right. Now we have some causes as well. Oh, please, can we all mute up, please? We have some causes of hypothyroidism. So number one is the autoimmune disorders. That is the Hashimoto's thyroiditis. That is the main cause of hypothyroidism. Please, if you see on your ankles and they give you a question and the question is asking you, which of the following is the major cause of hypothyroidism? And you see this Hashimoto's thyroiditis, please always go for it. Okay. When you see this Hashimoto's thyroiditis, always go for that. That one is the major cause or the number one cause of hypothyroidism. In this condition, there's an autoimmune trigger or an autoimmune disease whereby the release of antibodies because of the autoimmune reactions and autoimmune trigger, the release of antibodies will cause all right, I'll go back. Okay. Someone let me just go back again. Someone is asking me the types again. So I was talking about the primary hypothyroidism, the secondary hypothyroidism, and the congenital what hypothyroidism. The primary is because there's an issue in the thyroid gland. Okay, primarily there's something wrong in the thyroid gland. Then the secondary one, I was saying that the pituitary gland is the master gland. Okay, the pituitary gland is the master gland. So anytime there's something wrong with the pituitary gland, it is likely to affect all the other glands. Okay, likelihood that the other glands will be affected is very, very high. Let's not forget. So in the secondary hypothyroidism, it looks like the thyroid gland is functioning properly. Okay, or there's nothing really wrong with the thyroid gland, but then the pituitary gland is affected. Okay, the pituitary gland is affected. So because the pituitary gland is affected and it is the master gland, it will transfer the thyroid gland and it can cause a lower secretion of what? Of the thyroid hormone. Then the last one is the congenital hypothyroidism, which is also known as the paternism. So when a child is being born and then from birth, they have a low production of the thyroid hormone. Okay, that is the congenital hypothyroidism. Okay, very good. So the causes, we have the autoimmune disorders, and that one is the Hashimoto's thyroiditis. And I was saying that anytime you see on the NCLEX, they are asking that which of the following is the major cause of what? The major cause of hypothyroidism. Please go for the Hashimoto's thyroiditis. Okay. Always go for the Hashimoto's thyroiditis. In Hashimoto's thyroiditis, there's an immune trigger, and this immune trigger has released antibodies. Now, what these antibodies do is that these antibodies act on your thyroid gland and then it starts to destroy cells. Okay, when it acts on the thyroid gland, it starts to destroy the thyroid cells, and then this will contribute to a lower production of the thyroid hormone. So Hashimoto's thyroiditis is the number one cause of what? Of hypothyroidism. Two, a thyroid surgery like thyroidectomy. For example, if a patient is having hyperthyroidism and the patient has been scheduled for what? Thyroidectomy, and the surgery has been done to the point that um, we've now taken away the thyroid gland, there will be low production of the thyroid hormone because now the gland has been taken away. The gland that is supposed to do what? That is supposed to produce the thyroid hormone has now been taken away, leading to what? Hypothyroidism. We have radiation therapy. Okay, we have radiation therapy. So when you are exposed to too much rays for a longer period of time, the rays can as well do what? Have an effect on your cells in the thyroid gland, and then they begin to become destroyed by the rays. Okay, and this can contribute to what? This can contribute to a distraction of the cells in the thyroid gland, and then a low production of your thyroid hormones. Okay, very good. We also have radioactive iodine treatment. Usually, these things are done for a patient with hyperthyroidism. Okay, whereby we give them a radioactive iodine. You get it, and then this radioactive iodine try to destroy the cells of the thyroid gland. Okay, so when they destroy the cells of the thyroid gland, it can cause what do you call it? It can cause hypothyroidism because now the cells has been destroyed. Okay? The cells has been destroyed. So let's not forget that radioactive iodine treatment can also contribute to what? Can also contribute hypothyroidism. Then medications like amiodarone and then lithium. Lithium has a way of inhibiting the release of thyroid hormones like T3 and T4. Okay, lithium. Anytime a patient is taking lithium, it can contribute to or it inhibits the production of what? T3 and T4, and that one too can lead to for hypothyroidism. Then we have iodine deficiency, thyroiditis, and then genetic or family history. Iodine deficiency, we all know that the other time I was saying it, that the thyroid gland needs iodine to produce thyroid hormone. Okay, the thyroid gland there, it needs iodine like salt to produce thyroid hormone. So anytime your iodine is low or there's iodine deficiency, anytime there is iodine deficiency, okay, anytime there is iodine deficiency, the patient or the thyroid gland does not have enough, okay, the thyroid gland does not have enough of the thyroid gland to do what? The thyroid gland does not have enough of the iodine to prepare and then secrete the thyroid hormone. So there's going to be what? A low production of the thyroid hormone. So let's not forget that iodine deficiency contributes to hypothyroidism. And then we have thyroiditis, and then we have family issue. That is, if your family member have the condition, it's likely to extend to other family members. Okay. All right. Then the symptoms of hypothyroidism. Okay, so as we've been establishing, okay, in a hypothyroidism, there is what? There is low metabolic rate. Everything goes down in hypothyroidism. Everything goes down. Okay. As a memory trick, okay, as a memory trick, just know that anytime we hear hypothyroidism, just know that everything is going down. In hypothyroidism, everything is what is going down. Okay. There's nothing going up in hypothyroidism. So they have hypotensions, they have hypothermia, they have bradycardia. It's like everything is going down. So you can see hypotension, you can see weight gain. Okay, we can see cold intolerance. Now, these patients, the weight gain, they usually experience weight gain because there is low metabolic rate. Okay. So when a patient eats, even for metabolism to take place, it is not there. There is decrease in peristaltic movement, there is decrease in metabolism. So the patient does not even digest the food very well. They are just adding up, and that can increase or contribute to what? Weight gain. There can be cold intolerance, there can be hair loss. Okay, because there is diminished oxygen. In this patient, in this condition, the patient has what? Bradycardia and then bradypnea, low saturation. I mean, they can have low pulse rate and they can also have low respiratory rate. So even oxygen delivery is a problem in this patient. Okay, oxygen delivery is a problem in this patient. So even the hair follicles and then the glands on your skin that needs oxygen to produce the hairs are deprived of enough oxygen. That can contribute to hair loss. Okay, they can get constipation because there's decrease in peristalsis. So they can get constipation, can get bradycardia, as I said earlier on, can get bradypnea. Okay, they can get bradypnea, and then also they can get depression. Should I say that depression is almost linked with almost every condition? Okay, depression is almost linked with every condition because when a patient is sick, at the point in time you begin to become depressed and all this stuff. There can be memory impairment. You get a memory impairment when your brain is not getting enough oxygen. And when the brain is not getting enough oxygen, it can cause what? A reduction of how the brain functions because there's bradypnea over here. Because there is bradypnea over here, the brain will be deprived of oxygen at a point in time. Okay, and then this will cause what? This will cause a reduction in how the memory is supposed to function. Okay, but please, is someone talking? Hello. 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 Please, if you're not talking, kindly mute up. Okay. Okay. If you're not talking, kindly mute up. All right. Very good. So that is it. And then there can be muscle weaknesses, of course. And then it can lead to that one too can lead to low or irregular periods. When you have a slow metabolism, a slow, I mean, how there are processes in your body to contribute to a normal flow of menstrual periods have been affected because of the low production of the thyroid. There's going to be what? A low or irregular menstrual period. So these are some of the signs and symptoms of hypothyroidism. There's also hypothermia as well. Okay, that is why they are getting the cold intolerance. They are getting hypothermia. There's going to be a hypotension. So these are some of the signs and symptoms of hypothyroidism. Okay. Hello. All right. So we have the diagnostic test. We have the thyroid function test. Okay. And here in the thyroid function test, we are going to get a low T4, a low T3, and a high TSH. Okay, a low T4, a low T3, and then a high TSH. Let's not forget, okay. In hyperthyroidism, we have a high T4, a high T3, and a low TSH. But here we have a high TSH a low T3, and then a low T4. So, because the thyroid hormones, the T3 and the T4 are the major thyroid hormones that we have. Okay, these are the major thyroid hormones that we have. So the body or the thyroid gland is not producing enough of the thyroid hormone, right? So there's going to be a low T3 and then a low T4. Then, I have always been saying that anytime something is wrong in your body, there must be a compensation. Okay, it's like the body tries to find a way to overcome those challenges occurring in your body. Okay, so when the T3 and the T4 are low, that is when the thyroid gland is not secreting enough the thyroid hormone. When the thyroid gland is not secreting enough of the thyroid hormone, the body will try to compensate. So there will be a stimulation of what? Of the thyroid stimulating hormone as a way to compensate. So when this hormone have been stimulated, it's going to go high. Okay. So when you draw the levels of the TSH, you realize that it is very, very high because there's some stimulations going on as a way to compensate the low T3 and the low T4. Please, can we all mute up? All right. So that is what we all see. Okay. When the T3 and the T4 are low, as in the thyroid hormone production, what is the difference between free T3 and then there's no difference. Okay. There's no difference. They are the same. Okay. They are almost the same. Like, I mean, there's no specific difference between T3 and then free T3. Okay. They are just ways you can just find it the thyroid hormones. Okay. The T3 is what we call the triiodothyronine. Okay. And then the free T3, they just call it the FT3. Okay. They are related. Okay. They are related. They don't really have any distinct this thing. Okay. When you measure them in both hypothyroidism and hyperthyroidism. In hypothyroidism, they are all going to be low. Okay, and then in hyperthyroidism, they are going to be high. That is what you are just going to see. Okay, very good. So there's going to be a low T3, a low T4, and a high TSH. Okay, so there's going to be a low T3 and then a low T4, but then a high TSH. Okay, or a high thyroid stimulating hormone. Okay, because the stimulating hormone is trying to compensate for the reduction of the T3s and the T4. Okay, then you can also do the thyroid stimulating hormone receptor antibody test. Okay, so this test is a blood test that is used to diagnose all right, we do that. Okay, do that. Okay, this thyroid stimulating hormone receptor antibody test, it is done to help. Hello, please. Your question is if the problem is with the TSH, is the pituitary gland or the yes, the pituitary gland is actually where the secretion of TSH is. Okay, so it helps to stimulate the thyroid stimulating hormone, whereby these things are very, very high. But then, if the problem is with the pituitary gland and the pituitary gland is really affected seriously, hardly would we get a high TSH. Okay, because these thyroid stimulating hormones are coming from the pituitary gland. Okay, or they are being stimulated by the pituitary gland. So if the pituitary gland is also not functioning very well, it is not going to have that effect. Okay, it's not going to have that effect. But then, if the problem, or you are just focusing on the thyroid functioning test, okay, that is you draw the blood, or you are doing the thyroid function test alone, then you are going to have the high TSH with a low T4 and then a low T3. Okay. Very good. So I was talking about the second one, the thyroid stimulating hormone receptor antibody test. So this one too is done to diagnose either hyperthyroidism or hypothyroidism. Okay. This is done to diagnose whether hyperthyroidism or hypothyroidism. So this one, a blood sample will be taken. Okay, they will take a blood sample. Okay, then the blood sample will be analyzed for the presence of some enzymes. Okay. Please, can we all mute up? Okay, a blood sample will be taken from the vein in the arm, okay, and then they will test it to recognize the presence of some enzymes like the radio amino acids, okay. So that is what they test certain antibodies from the blood. Like example is the radio amino acids, okay, and this will help us diagnose the condition. So when you do this test, a negative result indicates that the enzymes are not present in the blood. Okay. But then a positive indicates that there's a presence of these enzymes in the blood. So when you do this test and you realize that there are enzymes like the radio amino acids, okay, or the amino sorbent acids, the helices and the rei. Once we do this test and we recognize that these enzymes are present, then it means that what is positive, and then it could show that the patient is having what do you call it? The thyroid function stimulating, or the patient is having what? Hypothyroidism. Okay, or there's an issue with the thyroid gland. So let's take note. You will just do, or we draw a blood test and then we test the presence of enzymes. Okay. When there's a presence of this enzyme, it shows that the patient or is having the hypothyroidism. Okay. Very good. Then three, we have thyroid ultrasound. Obviously, ultrasound is being done to know exactly what is going on in the thyroid gland, whether there are some dysfunction, if the size is okay, if there are abnormalities. Okay, so we can do the ultrasound as well. We can also do the fine needle aspiration biopsy, whereby a biopsy will be taken from the gland to visualize, the presence of the hormones or the amount of the hormones that is being there, so that it can also help us diagnose the condition. But please, let's take note, okay? Usually on the NCLEX, they limit it to the T3s, the T4s, and then the TSH. Usually, okay, we can get a case study, and the case study, the laboratory investigations on hypothyroidism or hyperthyroidism, you realize that the function or diagnosis that they brought for you to guide you make a diagnosis, you realize that it's only the T3, the T4, and the TSH. Usually they don't bring the aspiration, they don't bring the stimulating hormones and all this stuff. They just limit it. Usually, okay, I'm not saying always, but then most of the times they just limit it to okay, they just limit it to the T3s, the T4, and the TSH. Someone is asking of the what do you call it? The levels of the T3s. But on the NCLEX, if it's a case study, they will just bring the values. Okay. They will just bring the values. Okay. They are just going to bring the values. They will give you the normal values. Let me put it that way. Okay. They will give you the values for the T3 and then T4. Okay. But then if it's a case study, then you're not going to get. If it's a case study, you're not going to get. But then if it's not a case study, you're not going to get. But in case studies, you see the reference range. Okay, you realize that there's a reference range, and the reference range is what they are going to use to guide you to help diagnose the condition. Okay, but then if you don't get as a case study and it's like a traditional question, like the normal ABCDs, okay, then you should know the levels. So let me go over the levels. Okay, for T4, the levels are 5.0 to 12 ugram per deciliter or UG per deciliter. Okay, a normal T4 level in an adult, okay, is 5.0 to 12, and the T3 is 80 to 220 milligram per deciliter. Let me see. Yes. Okay. Yeah, nanogram per deciliter. Sorry, it is 80 to 220 nanogram per deciliter. So let's take notes. Okay, let's just take note of this. The normative.
Please again. Please again.
Okay, so the normal T4, okay, the normal T4 is 5.0 to 12.0 UG per deciliter. Okay, UG per deciliter. Then the normal T3 is 80 to 220 nanogram per deciliter. Okay, or NG per deciliter. These are the what do you call it? The normal levels for T3 and then for T. Very good. All right. So let's take note of that one. All right. So let's talk about the pharmacological management. Okay. Let's talk about the pharmacological management. Okay, someone is asking about the normal TSH. The normal TSH is 0.5 to 5.0. Okay, 0.5 5.0 milli per liter. So MLU per liter. Okay, MLU/L. That is for the TSH. That is for the TSH. All right. All right. Good. So the pharmacological management that we have for this patient. Oh, please, why are you not muted now?
And exercise.
Oh, let's mute up, okay?
Why are you not muted now? Amen. The what do you call it? Please, can you all hear me?
Yes, sir.
Yes, we can.
All right. Okay. Good. So the pharmacological management, usually these patients, we give them the levothyroxine, okay, the levothyroxine. And then for us to remember things about levothyroxine, let's remember this acronym, the level. Anything, or let me see, most of the things that NCLEX will ask you about levothyroxine has been shortened to this acronym or this mnemonic, the level, okay. Most of the things that NCLEX will ask you about this drug has been specified here. So the L stands for long life. So because the patient is not producing enough of the thyroid hormone, they must be on an artificial thyroid hormone for life. Okay, they must be on an artificial thyroid hormone for life. So they must be on this levothyroxine. The other name is Centroid. So let's not forget, if you don't see levothyroxine and you see Centroid, it's the same thing. Okay, levothyroxine or Centroid is the same drug. Get it? So it should be taken for life. That is the L. The L stands for life. The E stands for early morning or empty stomach. You shouldn't take this drug with food. This drug should be taken on an empty stomach or early in the morning. Okay, this drug should be taken early in the morning or on an empty stomach. Then the vein, it makes you very, very hyper. That is, when you take levothyroxine, you become agitated. Sometimes you can get confusions, and it increases your heart rate and your blood pressure. Please, let's take these are some of the side effects of the drugs. When you take levothyroxine, it can increase your heart rate and it can increase your blood pressure. Okay, it can increase your heart rate and it can increase your blood pressure. You can get tachycardia from taking levothyroxine. And then the O stands for baby is fine, meaning that it is not contraindicated in pregnancy. Pregnant women with hypothyroidism can take levothyroxine without any issue. Okay, they can take levothyroxine without any issue. You get it? You can take levothyroxine without any issue. So let's not forget this mnemonic, the level. L stands for long life, or lifelong. Okay, E stands for early morning or empty stomach. The VEN stands for very, very hyper. That is agitations, high BP, heart rate. And then O stands for the baby is fine with no problems. Okay, very good. So pregnant women can take it free of charge. All right. Then we can also give them vasopressors. Let's not forget, this patient has what? A low BP, there's hypotension. Okay, so we can give them vasopressors like the adrenaline to increase their BP. Okay, you can give them adrenaline to increase their BP because this patient is suffering from what? suffering from hypotension due to the low hormone level. So you can give them vasopressors. The vasopressors will constrict the blood vessels. Once there's that constriction of the blood vessels, it will contribute to an increase in the patient's what? In the patient's BP, okay, and it will help the patient prevent any complication. Okay. All right. Very good. Now, nursing interventions. We have to monitor the patient's weight daily. It's very, very important. This patient is just adding up weight. There is a slow metabolism. Okay. So why do you have to measure the patient's weight? Because there is slow metabolism. The patient is not breaking down food properly. So they are just piling it up. Okay. They are just piling it up, and this can increase the patient. So you must measure their weight daily. And then on the NCLEX, there's a way you measure their weight. Okay. There's a way that you measure their weight. Okay. There's a way that you have to measure their weight. You measure their weight with the same weighing scale, with the same clothing. Okay. With the same weighing scale and with the same clothing. That is something that you do. Let's not forget. With the same weighing scale and with the same clothing. Then, two, you nurse patients in a warm environment, and or you provide blankets for patients' use. Because this patient is having what? Hypothermia. There's also cold intolerance. They don't really have the capacity to be in a cold environment. So you must give them what? Blankets, cover themselves, or for the best thing, you nurse them in a warm environment, okay, to ensure that the place that they are being nursed have adequate heating system so that their body does not suffer from severe hypothermia. Okay. Today, you have to observe the patient BP readings very, very well. These patients have what? Hypotension. Okay. They have hypotension, a severe hypotension. So because these patients have severe hypotension, you have to monitor their BP, and then their BP is of concern over here to prevent any severe or hypovolemia or severe shocks. Okay. So their BP is of higher concern here. And then even this patient, because of their low BP, it can contribute to orthostatic hypotension. Okay, so you have to be observing for all these things. The static hypotension. Because of the BP, I want to ask this question, or I want to ask a question over here. Okay. Patients have a low BP in hypothyroidism to the point that, or a patient comes to, let me put it this way. You are an RN on duty. Okay, you are the RN on duty, and the patient is on a ward with hypothyroidism. You measure the patient's BP, okay, at 9 o'clock a.m. And then the BP was 70, 50 millimeters of mercury. Okay, 70, 50 millimeters of mercury. Then the patient also have an order for sildenafil at 10 o'clock a.m. Will you give this drug, or you will clarify this drug with the physician? What are you going to do?
You will not give. You have to question the drug because
Clarify.
it's a vasodilator,
Okay.
which will cause hypotension. So when you give it, you worsen it. So you have to
Okay.
clarify for your healthcare provider.
Please, question
Okay.
again. I didn't get the drug you mentioned.
Oh, okay. So the drug was sildenafil. Okay, I was saying that you are the iron on duty. Okay, you are the iron on duty, and then the patient with hypothyroidism is on your ward. You measure the patient's BP, and the BP recorded 70, 50 millimeters of mercury. Will you clarify sildenafil, or you give it? Okay.
Okay, thank you.
Yeah, and then someone answered that you are going to clarify because this drug also causes vasodilations and the BP would drop further. It is true. Okay, it is true. Oh, sildenafil, it is spelled S-I-L. Okay, Sildenafil. 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 It is also known as Viagra. Okay. It is given for men with or it is given to men with what poor ejaculations or premature ejaculation. Okay. Poor erections, premature ejaculation. It is usually given to these kind of men. Okay, so that is why we give this drug. Get it. Right. So you don't have to give this drug when the patient's BP is very, very low. Because this drug is a vasodilator, it is going to worsen the case. Okay. So sildenafil Another drug is tamsulosin. Okay, tamsulosin, TAMSU, LOSIN. Okay, tamsulosin. This drug too is given to patients with BPH. Yes, benign prostate hyperplasia. Okay, benign prostate hyperplasia. And then this drug was also given to relax the muscles around the bladder to allow free flow of urine. Okay, you give this drug to patients with what? With BPH so that it will relax the muscles around the bladder to allow free flow of urine. So this patient too, when you give this drug, it's going to cause a severe drop in the BP. So you don't combine it, okay? You don't give to patients with a low BP, but you are going to worsen the case. Okay. All right, that is it. Then 4, there are dietary changes, okay? There are dietary changes. You have to give them iodine-rich diet because if a patient have a low iodine levels, they can't produce enough thyroid hormone. Already, I have said it that the thyroid gland needs the iodine to synthesize thyroid hormone. So if the iodine levels are low, obviously the thyroid gland will not get enough iodine to synthesize their hormones. So their hormones are going to also low. So you must give them iodine-rich diet. You must observe the patient menstrual flow because patients are going to have irregular menses. Okay, so their menstrual flow is also a concern over here. Then you engage them in stress management because stress management can cause some complications. Okay, so you must also engage them in stress management. They shouldn't be thinking. You should calm them down. They shouldn't be have too much depressions. Okay, you must calm them down and then support patients with oxygen. Of course, patients have a low saturation or low respiratory rate. That is why you have bradypnea. So you have to support the patient with oxygen. Okay. Then engage the patient in regular exercises. This is also good. Let's not forget, we have to also give them what? High fiber diet. And then also what? Try and increase their fluid intake because the patient is going to have constipation. Okay, so because of the constipation, you must increase their fiber diet. Give them more fruits, more vegetables so that they can what? It can soften the stools and it can also help with peristalsis so that they can easily move their bowels. Okay, very good. Now, complication. Number 1 life-threatening complication of hypothyroidism is what? Mixed edema coma. Okay, so on your NCLEX, you had a question on hypothyroidism. They began with the history. Patient is having hypertension, bradycardia. Patient is having what? Cold intolerance. Then you start suspecting of what? Start suspecting hypothyroidism. Start thinking about hypothyroidism. Now you move ahead and check the laboratory investigations. You realize that there's a low T3, a low T4, and a high TSH. Then you conclude that the patient is having what? Hypothyroidism. The preceding questions and they ask you about oxygen administration. Okay, patient have hypothyroidism, or they ask you about vasopressors. You are going to give vasopressors. You are going to monitor their patient BP. What should you do? Okay, or which of the following is indicated or not indicated? You must give them high fiber diet. You must check their BP. You observe orthostatic hypotension. All these things can be done. Then your preceding history, or you read the nurse's note, okay, or the nurse's note. You read and the patient was going into coma. Okay, patient was going to coma, there's severe hypotension, or you realize that the BP has dropped as compared to the previous one. There's a low respiration as compared to the previous one. Then you should know that the patient is having what? The patient is having mixed edema coma. So mixed edema coma is a severe complication of what? Of hypothyroidism. And in mixed edema coma, it is nothing special. It is just a severe form of the hypothyroidism. The patient will present with the same signs and symptoms of hypothyroidism, just that here is in the severe form. And then this patient usually experience coma. Why do they get the coma? Patients with hypothyroidism have what? Bradypnea, low respiratory rate. Okay. And then when the respiratory rate is low, it means that oxygen delivery to vital organs in the body is also what? Impeded. And then one of the major organs in the body that really needs oxygen is the brain. Okay, is the brain. So in severe hypothyroidism, which is the mixed edema coma, patient goes into coma because there's a severe reduction in the patient's respiratory rate. Okay, their respiration rate are very, very low to the point that there is diminished oxygen delivery to the brain, and this can lead to what? A coma. So usually that is why this patient gets the coma. Now, this patient, the moment patient reports to your ward with hypothyroidism, and there's a complication, and then we diagnose mixed edema coma, please, their priority intervention here is oxygen delivery. Okay, their priority intervention here. So sometimes these patients, we even have to intubate them. Okay, we intubate them and we give them a mechanical ventilation as well, so that the patient will be able to have an additional support system for their oxygen delivery. Okay, so once we suspect or we realize that the patient is having mixed edema coma out of hypothyroidism, their priority here is what? Is oxygen. So let's not forget. Then later you can focus on the BPs and then the rest. Okay. All right. 2, we can get heart failure as a complication. Okay. We can get heart failure as a complication. You know, the lungs and then the heart are really, really connected, right? There's a clear relationship between the lungs and then the heart. Okay. So usually, anytime the lungs are not having enough or they are not functioning properly as expected, the likelihood that the heart will be affected is also high. Okay. That is something that we should know. And then even these patients, they can get what? Hypotension to the point that the heart does not have enough blood to even function. And then this can contribute to this can contribute to heart failure. Okay. So let's take note of that one too as well. When the heart is not having enough blood flow to help perform its functions, it can lead to heart failure. Osteoporosis. Okay. Anytime there is hypothyroidism, it causes a decreased activity of osteoblasts. That is bone formation. Okay, so hypothyroidism can contribute to the reduction of what? Osteoblasts, and then even osteoclasts. How the brain is how the brain is supposed to form is being reduced. Okay, and then because there's a reduction in osteoblast, there's rather going to be a compensatory mechanism by the bone, and this will cause the osteoclast, a consistent or frequent breakdown of the bone, and then the cells can lead to a breakdown, and this can lead to osteoporosis. Okay, so a patient with hypothyroidism has decreased osteoblast activity. Okay, the bone is not forming well. So because the bone is not forming well, what is going to occur? There's going to be a breakdown of the bone because the bone wants to compensate, and this will lead to osteoclast. And then when the bone tries to break down, it leads to a weakening bone, leading to osteoporosis. Okay, can get cognitive impairment. Of course, when there's diminished oxygen delivery to the brain will be deprived of oxygen, and how the brain should function is not going to occur. Okay, so it's going to be cognitive impairment. Then infertility because of the irregular menstrual flow or irregular menses. Okay, can contribute to infertility as well. So that is that for hypothyroidism. Okay, very good. Please, is there any question to ask? Is there any question to ask? If you don't have questions, me, I have questions. So,
Please, I have a question.
okay.
Okay, so you mentioned sildenafil,
Uh-huh.
and you said that dilates the vessels, and with hypothyroidism, every other thing like that, BP and everything is low because of the yeah. And then you also mentioned Tamsu something. I didn't really get that side, so I want you to
It's
help me.
okay. Yeah,
Tamsulosin.
tamsulosin.
Oh,
Okay, it is
For
given to a patient with
PH.
BPH or benign prostate hyperplasia. Okay, and then this drug is given to relax the muscles around the bladder to allow free flow of urine. Okay, and then because it has that effect of relaxing muscles, relaxing vessels, it can cause BP to drop. So you don't also combine or you don't also give the patient who has severe BP drop, okay, or severe hypotension. You are going to worsen the case. There are a lot of drugs like that. Okay, you have sildenafil, tamsulosin, terazosin. Okay, you know examples of, and then NCLEX tries to push you around some of these drugs. Okay, NCLEX will try to push you around some of these that should you clarify, should you keep? So let's try and know them. Okay, let's try and know them.
Okay, thank
All
you.
right. Yeah, you're welcome. Please, any other question, please? Any other question? Any other question? My people. This time you say my people.
Yes, sir. No question.
No
Okay.
question. Mm.
So, okay, if you are good, then I have some questions here. Okay, I have some questions to ask here. I have some questions to ask here. So, someone should read and then let's answer. Okay, so the questions, the combination of hyperthyroidism and hypothyroidism. Okay, so let's try and then answer them. Okay, let's try and answer them. So, can someone read?
Okay, I'm reading.
Okay, can read.
Which of the following assessment findings is characterized by thyroid storm? A. Increased body temperature, decreased pulse, and increased blood pressure. B. Increased body temperature, increased pulse, increased blood pressure. C. Increased body temperature, decreased pulse, and decreased blood pressure. D. Increased body temperature, increased pulse, and decreased blood pressure. We said thyroid,
Okay, so
hyperthyroidism. That one comes with everything being high.
okay,
Everything being high because metabolic rate is high. So with that, you have to choose all those that have high.
okay. So the answer is P, right? It is simple.
Yeah.
You know, sometimes you don't have to worry yourself and think. Let me put it that way.
Yeah.
On your NCLEX, there are some questions you don't have to worry and think. Let me say this, or let me put this across. On your NCLEX, one of the strategies that should help you move faster or answer questions is some of these things. There are some questions it will help you, or it's going to drain you a bit. Okay, you meet a question on your NCLEX and then you are going to spend like 3 minutes to answer. Those questions are there, or let me say 2 minutes to answer. Those questions are there. You have to think through. You have to apply before you can answer. Okay. But then there are also questions. You read the question and then you see the answer just plain over there. You don't have to overthink. You don't have to overthink. And some of them are some of these questions that we are solving. They increase BP, they increase pulse, and they increase blood pressure. Once you see thyroid stuff, don't try to even think around what is thyroid stuff. Blah, blah, blah.
Just
Okay.
exaggerated.
You just know that thyroid storm is everything is key. Please let me tell. So you know that in thyroid storm, everything is going high. Okay. So once you see thyroid storm, you know everything is going high. Just pick it and go ahead so that you will have enough time for the ones that will delay you a bit. So please let's take note, okay? On our NCLEX. Can we be with
Yes, we are having feedback too. Hey,
let's all mute up, okay? Okay, so on your NCLEX, the questions that the answers are straightforward. Please don't waste time. Don't waste time like some of these ones. Don't waste time. You just pick the answer, you go ahead so that you get time for those that you are going to think around them. Okay, very good. So we have the answer is B: increased body temperature, increased pulse, and increased blood pressure. So thyroid storm is characterized by SNS activation, sympathetic nervous system activation. Okay. The SNS over there is sympathetic nervous system activation. So the thyroid hormone will potentiate effects of catecholamines like epinephrine or norepinephrine. Therefore, all vital signs will be increased. Okay. So in thyroid storm, it is simply an exaggerated form of what? Of hyperthyroidism. So everything is going up. Okay. All right, let's look at our next question. The nurse is planning care for a patient with hyperthyroidism. Which of the following nursing interventions are appropriate? SATA, select all that apply. A, instill isotonic eye drops as necessary. B, Provide several small, well-balanced meals. C. Provide rest periods. D. Keep the environment warm. E. Encourage frequent visitors and conversation. F. Weigh the client daily. What are you going for? What are you going for?
Okay, so I'll take A, the eye drops, because they usually have think bulge eyes or something. And then we'll provide B. B, because of the hypermetabolism, they are always getting hungry and all that. So we need to be giving them well-balanced, small diet. And then they need rest periods as well. Yes.
Okay.
And then we need to keep the environment cool because they get warm, like there's heat intolerance for them. So they need cold environment. So D is out. And then I want to encourage frequent visitors or conversation because they need to rest. And then the weight gain is also important because they tend to lose weight. Oh,
Okay.
yeah.
Okay.
So
All
I'll
right. So
do
we are
A,
going for
B,
A, B, C,
and F.
A, B, C, and F, right? Okay. A, B,
Yes.
C, A, B, C, and F. All right. A, B, C, and then F. I think we are right. Let's see if we are right. All right. So the answer is A, B, C, and F. Okay. Someone said B, C, and F. A is needed for the exophthalmos or the bulging eyes. So let's see the rationale. Okay. The client with hyperthyroidism may experience exophthalmos. This requires installation of eye drops to prevent dryness and ulceration of the cornea. Okay, so they need the eye drops. Then B and F, the client expressing weight loss because of hypermetabolism. Okay, so several small, well-balanced diets are given to improve what? Okay, so a well-balanced diet to improve the nutritional state of the client, and daily weight should be monitored. Weight is the most objective indicator of nutritional status. Okay. C. The client is usually exhausted due to restlessness and agitation. The client is usually exhausted due to restlessness and agitation. Frequent rest period help the client to regain energy. So the answer is A, B, C, and then F. Okay. All right. Let's do the next question. After thyroidectomy, which of the following is a priority assessment to observe laryngeal nerve damage? Before we do this question, the other time when we did the thyroidectomy, okay, I gave four major, let me say, complications after thyroidectomy has been done. Who can remind us the four major NCLEX interest after thyroidectomy has been done?
Okay, we said there will be blood at the back of the neck. Then there will be
Okay.
laryngeal hoarseness. There will be hoarseness of the voice. I think for now, it's two that I've remembered.
Okay. Can
I
someone
think
remember?
bleeding,
I said for
bleeding, stridor.
Hypoparathyroidism.
There's
Titani.
Because of
yes.
the
She was
Hypocalcemia.
sign here.
Okay, and then the last one. The last one. Okay. All right. So I said basically on the NCLEX, they test us on four major things. Okay. They test us on four major things after thyroidectomy. So infection, bleeding, hypocalcemia, and stridor or stridor. Okay. Infections, bleeding, hypocalcemia, and stridor. Let them just go do a quick recap on these four. What you expect. So in bleeding, you are experiencing what? Blood or poo at the back of the neck or frequent swallowing. In hypocalcemia, you're expecting what? Foxted sign and Trousier sign. In infections, what are you expecting? High temperature, high white blood cell count. Okay. Then stridor, we are expressing what sometimes hoarseness of the voice and then a severe respiratory what impairment. So let's not forget, okay, a severe respiratory impairment. So let's not forget. All right. So let's pick the answer for this question. Which of the following assessments will let us observe a laryngeal nerve damage?
Hoarseness of voice.
Okay, hoarseness of voice. Okay, this one will not waste time. Okay. So laryngeal nerve damage is manifested by severe hoarseness of whispering voice. Okay. Severe hoarseness of whispering voice. So this one, of course, when the laryngeal nerve has been damaged, there's going to be hoarseness of voice. All right. I have a question here. This question, you must read it very well and understand before you pick the answer. So I'm reading the question. Okay. An incoherent female client. Please can you mute up? An incoherent female client with a history of hypothyroidism is brought to the emergency department by the rescue squad. Physical and laboratory findings reveal hypothermia, hypoventilation, respiratory acidosis, bradycardia, hypotension, non-pitting edema on the face and periorbital area. Knowing that these findings suggest severe hypothyroidism, Nurse Libby prepares to take emergency action to prevent the potential complication of A. Thyroid storm, B. Cretinism, C. Mixed edema coma, D. Hashimoto's thyroiditis.
Mixed edema coma.
Edema coma.
Okay, so I just spoke about it. So this one there is Fala, right? I just spoke about it. So it is Fala. So mixed edema coma, a severe hypothyroidism may result in mixed edema in which there's a drastic drop in metabolic rate, causes decreased vital signs, hypoventilation, non-pitting edema. Okay, thyroid storm is an acute complication of hyperthyroidism. Cretinism is a form of hypothyroidism that occurs in infants. That is what I was speaking about. Okay, the first slide. So cretinism is simply a hypothyroidism in children. Okay, and Hashimoto's thyroiditis is a common chronic inflammatory disease of the thyroid gland in which autoimmune factors play a prominent role. Okay, very good. So that is that. Maybe this will be our last question, or last but one question. Let's answer it fast. Someone should read for us, okay?
Nurse Oliver expects a client with hypothyroidism to report which health concerns.
Are you done? A.
Read the answers.
A. Increased appetite and weight loss. B. Puffiness of the face and hands. C. Nervousness and tremors. D. Thyroid gland swelling.
What are you going for?
B.
B. Okay. Okay, so of course, puffiness of the face and the hands. So hypothyroidism, mixed edema, causes facial puffiness, extremity edema, and weight gain. Okay, signs and symptoms of hyperthyroidism include appetite, weight loss, nervousness, tremor. So the rest of the options all goes for hyperthyroidism. Okay. All of the rest of the options go for hypothyroidism. So that is it. All right. Next question. Can someone read for us?
Early this morning, a female client had a subtotal peridectomy. During evening rounds, Nurse Tina assesses the client, who now has nausea, a temperature of 105 degrees Fahrenheit, that's 40.5 degrees Celsius, tachycardia, and extreme restlessness. What is the most likely cause of these signs? A. Diabetic ketoacidosis. B. Thyroid crisis. C. Hypoglycemia. And D. Tetany.
There is B. Thyroid crisis.
Thyroid crisis.
Okay, wow. I like the way you really understood this topic. Okay, the hyper, the hypo, it's very, very good. Okay, so it is thyroid crisis. Okay, thyroid crisis because everything is going on. So please, I'm sure we all know if you don't see thyroid crisis, what would you see? So in case the NCLEX does not bring thyroid crisis, what would they bring?
Thyrotoxicosis.
Very good. So it is either thyroid crisis, thyrotoxicosis, or thyroid storm. They are all the same. Okay, thyroid crisis, thyrotoxicosis, and then thyroid storm. So let's not forget. Okay. All right. So thyroid crisis usually occurs in the first of hours after thyroidectomy and causes exaggerated signs of hyperthyroidism, such as high fever, tachycardia, and extreme restlessness. Do you know that even though thyroidectomy is going to take away the thyroid gland, there still can be thyroid crisis. But please pay attention, okay? Again, let me remind us, please, on your NCLEX, anytime I'm reading a question, pay attention to details, okay? Pay attention to details. Just read the first sentence of the question. Early this morning, a female client had a subtotal thyroidectomy, not a total thyroidectomy. If the patient had a total thyroidectomy, there's no way the patient will have high symptoms because the thyroid gland has been taken away. But because it's a subtotal, meaning a portion were taken away and then the rest were left. So meaning that there can still be a production of thyroid hormone. Okay, please let's take note. And then the moment the thyroid gland has been stressed or has undergone stress like surgery, it can cause thyroid crisis. Okay, stress on a thyroid gland can cause what? Thyroid crisis. So let's not forget. Okay, so thyroid crisis usually occurs in the first of hours after thyroidectomy and causes exaggerated signs of hyperthyroidism, such as high fever, tachycardia, extreme restlessness. EK is most likely to produce polyuria, like to produce polyuria, polydipsia and polyphagia, hypoglycemia to produce weakness, tremors, profuse what? Perspirations, and hunger. Tetany typically causes uncontrollable muscle spasm, stridor, cyanosis, and possibly hot asphyxia. Okay. Very good. So that brings us to the end of what? Hyperthyroidism and hypothyroidism. We are moving on to the next topic under the endocrine. Please, are we all on the same page?
Yes, sir.
Yes, please.
Yes, please.
Everything is going on well. Please, I want to know.
Yes, boss.
Okay, all right. And are you enjoying the class?
Yes,
Very
we are
Yeah,
enjoying.
boss.
Please,
We're enjoying
yeah,
it very
please.
well.
Hello,
Okay.
please let me take you back briefly concerning the osteoporosis as the
Okay.
complication. Yes. And then you mentioned that there is decreased osteoblast
Osteoblast.
activity. Please, yes, I want you to touch on that side of it. Just
Okay,
briefly.
so I was saying that hypothyroidism has a way of reducing the activity of osteoblast. It means that osteoblast is how the bones are being formed, okay, or how the bones are being built up, okay. So when the thyroid glands are not being produced enough, it can contribute or it contributes to the cells not what engaging in enough formation of the bone or build up of the bone. Because of this, how should I say? The bone is not what building itself very well, or the cells are being weakened to the point that it's not going to build up itself naturally, okay, or the natural process is not being achieved. So the bone in your body will try to compensate. Okay, if the body will not help me build up my bone, I have to find a way myself as a bone. So now let me undergo consistent osteoclast. Osteoclast is when the bone begins to break down. Okay, the bone begins to break down to form itself. You get it? That is osteoclast. So because the body is not helping the bone build itself, now the bone has taken the duty on its own. So they undergo frequent or consistent. Okay, they undergo frequent or consistent osteoclast. So they are breaking down the bone consistently. So because there's a consistent osteoclast or consistent breakdown of the bone becomes very, very weak, and that can lead to osteoporosis. Okay. All right.
It's clear now. Thank you very much.
You're welcome. Okay. And even with that, let's not forget, osteoporosis can also affect the metabolism of and hypothyroidism can affect the metabolism of calcium and then vitamin D. And even that one can lead to a decreased bone density. So let's no, please, let's get this clear. Graves' disease is not the same as hyperthyroidism. No. Graves' disease is a cause of hyperthyroidism. In Graves' disease, there's an autoimmune disorder. This autoimmune disorder has caused the release of antibodies, okay? And then these antibodies is triggering the thyroid gland to produce more thyroid hormones. Please, let's get it clear. Graves' disease is not the same as hyperthyroidism. Actually, Graves' disease is a cause of hyperthyroidism. Let's try and get the difference between Graves' disease, hyperthyroidism, thyroid storm, thyroiditis. Let's get all the difference, okay? Graves' disease is a cause of hyperthyroidism. Graves' disease is an autoimmune disorder which triggers the thyroid gland to produce more thyroid hormone. And then thyroid storm is a complication of hyperthyroidism. Okay. All right. Are we okay?
Please, I have a question.
Okay.
Yeah, just a little confusion here. The previous question before this one, the previous
Okay.
one.
Yeah. Please can it has done what? Or I should go over.
Yes.
I should go over the osteoporosis.
No, not the osteo. I'm talking about the question. Anyway, let me just go straight and ask. So for hyper and then hypo, which one causes the oversecretion of the thyroid gland? You know, where they have the swelling. Is it the hypo or the hyper?
Usually or basically the hyper. Okay, basically the hyper.
Okay.
Yeah.
Okay.
The
But then
hyperthyroidism is where the hyperthyroidism is whereby there's an overreactive thyroid gland. The thyroid gland is located, the thyroid gland is located in front, or let me say at your neck region. So when there's an overreactive thyroid gland, it leads to swelling. Okay, and then you see that goitatem. Okay.
Yeah.
Yes.
Okay. All right. Okay. Thank you. So for the hypo, you don't have that. It doesn't.
Yes.
They don't have the.
Yes.
Okay.
Usually,
All right.
if the hypo will get that, then it's in the long run. That is when the body
The
tries to
long.
compensate. Okay.
Exactly. Okay.
The long run, when
All
the
right.
body tries to, because there's low thyroid hormone, the body will try to compensate. There is the cause and saturation of overreactive thyroid gland, which leads to the swelling. But in initial stages, you don't get that swelling in hypothyroidism.
Right. Okay. So eventually it can. So when you see, you know, the swelling, it doesn't mean that it is just hyper. It can also be
Yes.
hypo.
Okay.
All
Yeah,
right.
exactly. But
All
now
right.
it's in the
Okay.
long run.
Right.
Right.
Okay. Thank you.
You're welcome. You're welcome. Please, any other question? Any other question? Any other question? Let's move on to Addison's deficiency syndrome. Addison's deficiency syndrome. Are we okay? Can we move ahead? I want to confirm.
Can move ahead.
All
Yes,
right.
please, we can.
Good. So Addison's disease and Cushing syndrome. You know, this one is one of the major questions you can get from my NCLEX. Addison's and Cushing. In fact, I will not lie to you. Okay? You are likely to get it. It's one of the most common topics on the NCLEX. Addison's and Cushing. So I would like us to go through it. Okay, right. So Addison, let's begin with the Addison's disease. So Addison's disease is a condition characterized by inadequate production of cortisols, steroids, and aldosterone hormones by the adrenal gland. Okay, can someone help me? I'll give the person Aliwa after class. Okay, which part of the adrenal gland does Addison's disease and Cushing syndrome
The
occur? Which part of
cortex. The cortex.
Cortex.
I'll give you Aliwa, okay, after class. And then, okay, let me add a follow-up question. Okay, let me ask the follow-up question. And then, which condition affects the medulla of the adrenal gland?
Pheochromocytoma.
Very good. Pheochromocytoma. Everyone wants to give the Aliwa.
Natural Science and Math quiz.
Okay. So the Addisons and the Cushings affect the adrenal cortex alone. Okay. Then the medulla is for the pheochromocytoma. Okay. So let's take. So in Addison's disease, it's a rare endocrine disorder, okay, whereby there's a low production of cortisols, steroids, and aldosterone hormones by the adrenal gland. Okay. So in this patient, the adrenal gland is not producing now the adrenal hormones. Okay, the adrenal hormones are the cortisols, the steroids, and then the aldosterone. Okay, so let's take the steroids. We have the glucocortisols, the mineralocortisols. All of these are under the hormones of what? Of the adrenal gland. Okay, so let's take. But here in Addison's, they are not producing enough. Okay, you know, one thing that makes the endocrine system very, very interesting is that it's just opposite, highs and lows. Okay, one is high, the other is low. One is high, the other is low. It is just like that. So you just pair them. So in other sense, it is, or let me say in the endocrine system, you can just learn one condition under each of the gland. Just learn one, and then just relate to the opposite side when you are talking about the other. Okay, it's as simple as that. All right, so the types of the Addison disease, we have the primary, the secondary, the tertiary, and then the congenital adrenal hyperplasia. So the primary is when the issue is in the adrenal gland. Okay, again, the primary adrenal insufficiency is when the issue is in the adrenal gland. Okay, meaning the adrenal gland is not functioning very, very well. There's an inflammation, there's an infection, there's a malfunction of the adrenal gland, and it has contributed to the fact that it is not producing enough of the cortisol, the steroids. Okay. Two, the secondary adrenal insufficiency is when the pituitary gland is dysfunctioning. Once again, the pituitary gland is the master gland. Anytime the pituitary gland has been affected, it can affect the other kinds of glands. Okay, so that is when you get the secondary insufficiency. And the tertiary is the hypothalamic dysfunction. Do you know the hypothalamus? Below it is the pituitary gland, right? The pituitary gland is just below the hypothalamus, so they are related. So if something occurs to the hypothalamus, it can extend to the pituitary gland, okay, and it can affect the glands in the body. That is where we get the tertiary one. And the last one is the congenital adrenal hyperplasia, the genetic disorder. That is when through birth and then through genetic mutations, there is this abnormal group of cells in the adrenal gland, and it can contribute Addison. Okay, right. Now let's look at the causes. Okay, let's look at the causes. We have autoimmune adrenalitis. That is an inflammation of the adrenal gland, and this one too is an autoimmune disorder. That is when there's release of antibodies, and these antibodies act on the what do you call it? These antibodies does what? Act on the adrenal glands, and it destroys what? It destroys the hormones, and they are not being producing what? In excess, or they are not produced as expected. Then we say the person is having what? Is having hypoadrenal production, so leading to Addison disease. Okay. Two, we have tuberculosis. Someone can ask, how can tuberculosis cause hypo or Addison disease? Let's not forget, okay, or let me say to give us this information. Tuberculosis can really cause Addison disease. What is that? Is that tuberculosis infects and it can destroy adrenal glands, okay, and then it can reduce the production of what? Of aldosтерons and then cortisols. Okay. Sometimes TB forms what we call the granulomatous inflammation. Okay, and this can cause the reduction of the adrenal hormones. Okay, and then also what TB does is that TBs can cause calcification of the adrenal gland. Get it? It causes calcification of the adrenal gland. And when this calcification occurs, it leads to a damage of the adrenal gland, and then the hormones are underproduced. All right. Three, we have adrenal gland injury or trauma. Of course, if something occurs to the adrenal gland, okay, or if there's an injury to the adrenal gland, it can affect the way the adrenal gland functions, and then the production of the adrenal hormone will go down. We have cancers, we have infections. You know, all these can contribute to low production of adrenal hormone. Okay, tumors are in the adrenal gland, cancers, we have genetic mutations, we have radiation therapy. Okay, if you are exposed to radiation, this one is like it can affect all the glands. The radiation therapy, when we are exposed to too much rays or radiations, the rays can kill the cells in the body. Okay, it begins to kill the cells in your glands, and then this will cause a low production of the hormone with respect to that particular gland. Okay. So autoimmune adenitis, tuberculosis, adrenal gland injury or trauma, cancer infections, genetic mutations, radiation therapy are some of the causes of what Addison. Now let's look at the symptoms. We have bronze hyperpigmentation or skin darkening. Please let's take. This is also one of the key or enkless tips about Addison's. In fact, about 90% of the questions you are going to see on Addison, you are going to see bronze hyperpigmentation. It's like the enkless cannot bring a question on Addison without attaching this bronze hyperpigmentation. So one of the symptoms is the bronze hyperpigmentation, and then this occurs, when the Addison's hormones are low, okay, or when the adrenal gland hormones are low, and there's Addison's disease, there will be a stimulating of what we call the adenocorticotrophic hormone. The adenocorticotrophic hormone will be stimulated, and this will cause an increase in melanocytes, and then there will be an increased production of melanin. Okay, so this will increase how your skin becomes dark. You get it? There's a low production of adrenal hormones leading to Addison's disease, and then this will cause a stimulation of what? The adenocorticotrophic hormone. This will produce more melanocytes and then increase melanin production, leading to what? Bronze hyperpigmentation. Okay. 2, we can get orthostatic hypotension. Now, good. Let me explain certain things over here. Cortisols, okay? Cortisols are needed in the body to do what? To help with BP regulation, to help with sodium, and then electrolyte balances. It also helps with sugar control. These are the basic function of cortisols, and then steroids, okay? They help with BP control, with electrolyte balances, and then it also helps with what? With sugar level. You get it? Let's take note of the function of what? Cortisols. Now, if the cortisols are low, it means that how the BP is being controlled is going to go down. Okay, so you can get hypotension. And then let me take this opportunity, or let me explain this right here. Okay, aldosterone is also an adrenal hormone. Okay, aldosterone. Please, I want you to listen here very, very well, because if you don't get it, get confused along the line. Okay, aldosterone is also an adrenal hormone. Usually, or normal, as a normal human being like you and I, when you have a normal aldosterone level, it is supposed to do what? It is supposed to hold or retain sodium and excrete potassium. Please take note. Normal aldosterone levels contribute to the fact that it helps the body retain sodium and excrete potassium. But in a situation whereby the patient does not have enough of the aldosterone, that purpose, that activity of the aldosterone to hold the sodium is not there. Okay, and then to excrete the potassium is not there. So the sodium now begins to leak out. They can't retain the sodium now because the aldosterone is low. So sodium begins to leak out, leading to hyponatremia. Then instead of the potassium going out, they are now being retained, leading to hyperkalemia. Okay, so in Addison's disease, we have hyponatremia, hyperkalemia. Now, if you have hyponatremia and then your salt is going out, it means water will follow. So water will also begin to go out. And then if you begin to lose water, your intravascular volume will deplete, and even that one can contribute to hypovolemia and hypotension. Okay. So we have hypotension as part of the symptoms. We have hypovolemia. We have 4, low sodium and high potassium. Okay, low sodium and high potassium. Then 5, we have hypoglycemia. Another function of cortisol, cortisol helps in glucogenesis. That is, it helps in the synthesis of glucose. So if the cortisols are low, glucogenesis will not be achieved, and then glucose level is going to drop. Okay, so we have glucose level. 6, we have salt cravings because sodium is now leaking out. So we are going to lose a lot of sodium, a lot of salt, and this can contribute to salt cravings. We can get anemia. Okay, you can get weight loss. there can be weight loss because you're going to lose too much water. Because of this, there's going to be fatigue, dizziness, and there can be massive pain. Okay, so these are some of the key signs and symptoms of what Addison disease, especially the bronze hyperpigmentation, the hypovolemia, the hypotension, the low sodium, the hypotassium, and the hypocalcemia, salt cravings. At least these 6. Anytime you get a case study on Addison, you should find these signs and symptoms to help you diagnose the condition. Okay, to help you diagnose the condition. All right. Now, diagnostic tests. We have the morning cortisol levels. Okay, we have the morning cortisol levels. So why are we doing the morning cortisol levels in Addison? Is because cortisol levels are high in the morning, especially in between I think 6 a.m. Okay, 6 a.m. 7 a.m. You have more of your cortisol levels there. So they will draw a blood sample to test for the cortisol levels in the morning when they want to diagnose Addison disease. So when they draw the blood sample and they test the cortisol levels, okay. So we have the anemia, we have the weight loss, the fatigue, dizziness, and muscle pain. Okay, these are some of the signs and symptoms of Addison. Okay, all right. Very good. So the morning cortisol, I said that early in the morning, usually you have high cortisol levels. In the mornings, you are going to get high cortisol levels in the morning. So we want to see that if the patient cortisol level will be high, okay, in the morning. So in the morning, you will draw a blood sample and then we test for the presence of cortisols. Check whether it's going to be high. If it is high in the morning, it means that the patient does not have Addison disease. But then, if we test it in the morning, and the patient does not have a high cortisol levels in the morning, then it means the patient have Addison disease. Because usually in the mornings, we should have a high cortisol level. Okay, we should have a high cortisol level usually in the morning. Okay, so if we test in the morning and the cortisol level is low, it means that the patient is having Addison disease. So let's not forget. Okay, let's not forget. The normal cortisol level is 5 to 25 microgram per deciliter. Please, let's take note. Okay, 5 to 25 microgram per deciliter, especially in the morning. That is around 8 a.m. If you do around 8 a.m., you should get cortisol levels around 5 to 25 microgram per deciliter. So when you do this test, and the patient's cortisol level is below 5 or is very, very low, and it means that the patient is having Addison disease. Because in the mornings, you should get a high cortisol level. Okay. So we can do adenocorticotrophic hormone stimulation test. Okay. So in this one too, we are going to give you an artificial ACTH hormone. Okay. We will give you an artificial adenocorticotrophic hormone. Okay. But before we give you that artificial one, we will draw your blood and then test your cortisol levels or the ACTH hormone levels as a baseline. Okay. So we draw it and we test and we do the baseline. Then after that, we give you the artificial hormone. When we give you the artificial hormone, later after 30 minutes time, you will then draw the blood again and then test for the presence of this ACTH, okay, the adenocorticotrophic hormone. Now, if the levels increase, then it means that you have what? You have Cushing syndrome, or it is normal. But then if the levels reduces, then it means that you have what? Addison levels of their cortisol, adenocorticotrophic hormone should be low. Okay, then you can do imaging studies like CT scan or MRI. Okay, we do CT scan or MRI to visualize what the adrenal gland very, very well. Okay, then 4, we can do adrenal gland biopsy. Okay, an adrenal gland biopsy. So we take a biopsy on an adrenal gland and to help us also detect the presence of the adrenal hormones or the presence of cortisol. Okay.
Please, the ACTH, can you repeat that, please? The one you say we have to first of all draw the blood to do the test before we give the adenocorticotropic hormone. Oh, I didn't get the explanation very well. the results.
Okay.
Can you start
Okay,
from
so
the modern cortisol for us? Because that place you were fast, the 1 and 2.
all right. So let me be slow. So the morning cortisol levels, usually, okay, or on a normal day, your cortisol levels are high in the morning. Okay. The normal day, your cortisol levels are very, very high. You can get like 25, 26 during the morning, around 8 a.m., 7 a.m. So, because cortisol levels are high in the morning, we want to use it as a way to diagnose Addison. So, we will draw your blood and then test for the cortisols in the morning. Now, if your cortisol level does not go up in the morning, then it means that you have Addison, because under normal circumstances, you should have a high cortisol levels in the morning. Okay. So if you do your test in the morning and then you get the cortisol level around 3, 4, or 5, then it means that your cortisol levels are very, very low, which is not ideal for morning cortisol levels. Then we can conclude that you have what? Addison's disease. Okay, very good. Now, the adenocorticotrophic hormone stimulation test. Okay. Now, this one, how do we do it? First of all, we will draw your blood. Okay. When we draw your blood, and when we draw your blood, you will take a baseline of your cortisol levels. Okay. So you take a baseline of your cortisol levels, then write it down. Now, after that, we will give you an artificial adenocorticotrophic hormone. Example is the cosipnotropin. Okay, we will give you an artificial one of the hormone, and then you take it. If you take it, it is given IV. Okay, we give it to you IV, and then you have it. When we give it to you, 30 minutes to 30 minutes time, you will now come and then check your cortisol levels again. Okay, you will now come and check your cortisol levels again. Now, if we check your cortisol levels after 30 minutes and 60 minutes, and then it does not increase, then it means that you have what? You have Addison disease. Because now we're giving you a hormone. Okay, we're giving you a hormone. So if the level does not increase as compared to your baseline, then it means that you have Addison's disease. Are we okay? Are we okay? Hello.
Yes, we are.
Okay.
Yes.
All right. So we can also do the imaging studies. And I said that the normal cortisol levels in the morning is 5 to 25 microgram per deciliter. It is 5 to 25 microgram per deciliter. But in the evening, around 4, 5, 6, I don't know, thereabouts, like 8 p.m., it goes to like 3 to 10 microgram per deciliter. Okay. It's around 3 to 10 microgram per deciliter. So this thing goes down in the evening. It's high. Now, pharmacological management, okay. Of course, the patient is not having enough of the steroids. It's not having enough of the cortisols. Please, can we mute up? Someone's microphone. Okay, so we have a low cortisols, we have a low mineralocortisols, we have low steroids, in Addison's disease. So the pharmacology, usually we give them what? An artificial steroids. Okay. So you must replace it. You can give them the hydrocortisone, the cortisone. So all these must be then given to the patient. The prednisolone, these drugs must be given to replace the low production of the adrenal, the cortisols. You must just replace them. Okay. So you are giving the cortisols replacement, the mineral cortisols replacement, replace what? The low production of the adrenal. And then we can give them vasopressors as well. Okay. You can give them vasopressors because they have a low BP. Okay. They have a low BP because of the reduction in the food. So we have to give them vasopressors. So we have to give them vasopressors. Yeah. Right. So these are some of the drugs that usually keep the patient with Addison. Now, nursing intervention. Okay. is here to, you have to pay rapt attention over here because NCLEX is of higher
Sir,
interest in this.
can you please go back
Yeah,
to the back? Can you please go back? Yeah, just okay. Thank you.
okay.
Right, thank you.
All right. So the nursing management, we have stress management. As we'll be discussing in our next slide, okay, the Addisonian crisis is also a severe form of the Addison disease. One of the major cause of Addisonian crisis is stress. Okay, is stress. So if a patient have Addison disease, you have to really manage their stress. You get it. You have to psych them. You have to talk to them, relieve any depressions. You have to engage them, diversional therapies. To calm them down so that they are not frequently stressed because stress can cause Addisonian crisis. So they must undergo stress management, regular exercise. All this helps their stress level. Okay. 3, you have to increase their salt and water replacement. Of course, patient is losing all their sodium, right? Patient is losing all their sodium because there's a low aldosterone level. So because patient is losing all their sodium, we must replace salt and then water, okay, to respond to the issue. All right. You observe for cardiac arrhythmias because there's going to be what? Hyperkalemia. Okay. There's going to be hyperkalemia. The patient is supposed to excrete potassium, but then because the aldosterone levels are low, and because the aldosterone levels are low, and it is going to cause a retention of potassium rather. So there's going to be hyperkalemia. Hyperkalemia can trigger cardiac arrhythmia. So you have to do what? You have to give, or you have to observe for cardiac arrhythmias. You initiate cardiac monitoring, okay? You initiate cardiac monitoring, and then you respond to the situation as such. So even this patient, you must reduce their potassium-rich foods, okay? You must reduce their potassium-rich foods. It is very, very important. You must reduce their potassium-rich foods. Okay. All right. Good. 6, monitor patient blood pressure. Of course, there is hypotension. Okay, there is hypotension. So you must monitor the patient's blood pressure very, very well. They must wear a medical bracelet.
Oh,
Yes,
sir,
they must
there's
wear.
feedback. There's lots of feedback. Could you
Yes,
please mute those on mute?
I've been saying this since the beginning of the class. I wish all maybe have other. All right. Okay, so this patient must wear a medical bracelet. Okay, this patient must wear a medical bracelet because especially if they get into the Addisonian crisis, it's very, very serious. They must wear the medical bracelet so that we respond to the situation as fast as possible. Then 8, you monitor their patient glucose level. Okay, monitor patient glucose level because there is low adrenal hormones. Okay, there is low adrenal hormones, and because there is low adrenal hormones, what is going to occur? There's going to be no glucogenesis. Okay, there's going to be no glucogenesis, and glucose level is going to go down. So you must respond to the situation and prevent hypoglycemia as fast as possible. Then 8, they must take in balanced diet. Of course, okay, they must take in a balanced diet with high calories and then with adequate salt. Okay, because usually these patients crave for salt. Okay, all right. Complications of Addison disease. We are getting Addisonian crisis, as I said. Now, let me tell you some NCLEX interest when it comes to Addisonian crisis. So you can get the question on Addison disease as a case study on your NCLEX. You have seen all your history. There's hypotension, hyponatremia, hypoglycemia, hyperkalemia. Everything is there. You've seen it. Okay. Then they bring a follow-up question. They bring a follow-up question. And then the follow-up question is around Addisonian crisis. You get it? It's around Addisonian crisis. What are the things? Yeah, they are making noise. I'll beat you. All right. Okay. So, what are some of the things that you should know as a causative factor or factors that precipitate Addison crisis, Addisonal crisis? One is stress. Okay. If the patient undergoes stress, likelihood that the patient will get Addisonal crisis is very, very high. So stress, that is one. Two, infections. Okay, infections. When a patient is being exposed to a lot of infections with Addison's disease, they can get Addisonian crisis. And you know something? Let's not forget that when a patient is taking steroids, in Addison's disease, what do? We replace the steroids. We give them artificial steroids. Let's never forget that when a patient is taking steroids, and steroids can deplete the immune system functioning. Steroids reduces the function of the immune system. That is, after you begin therapy on steroids, the capacity of the immune system to fight infections goes down. Okay, so you are prone to infections. So because of that, persistent infection can predispose the patient to getting an Addisonian crisis. So let's not forget, stress and then sepsis can cause Addisonian crisis. 3, when the patient stops the steroids abruptly. So under no circumstance should you stop steroids abruptly. Like all of a sudden, and the patient have stopped the steroids abruptly. So on the NCLEX, you can get the question: a patient with Addison's disease has been discharged home. Okay, and then you as the RN, you are reviewing the discharge plan with the patient. Which of the following statements made by the patient will indicate that further education is needed? 1, if the patient says that I can stop taking steroids if the symptoms go down, please, it is wrong. They shouldn't stop taking the steroids. Actually, steroids are being taken for life. Okay, they shouldn't stop taking the steroids if the symptoms go down. Abrupt withdrawal or abrupt stoppage of the steroids can cause Addisonian crisis, which is a severe life-threatening complication of Addison's disease. Okay, so let's not forget. Now, in Addison's disease, what do? You have to give the steroids IV. You no longer don't give the steroids orally. Okay, you have to give it IV. So respond to the situation as fast as possible. So you have to give the steroids IV. Okay, instead of oral or any other route, you give the steroids or IV to respond to the situation as fast as possible. And then in the Addisonal crisis, the symptoms are the same as what? Addison's disease, but here in the severe form. Okay, there's going to be severe hypotension, severe hypoglycemia, severe hyponatremia, and severe hyperkalemia. So in Addisonian crisis, patient is at higher risk for getting hyperkalemia or cardiac arrhythmias. Okay, so that is that for Addison's disease. Another complication is hypotension. I think I've said this earlier on. 3, you can get electrolyte imbalance. I have said it. Okay, there is hyponatremia, hyperkalemia. 4, there is dehydration because sodium is going to go out. If sodium is going out, water will follow, and that can contribute to dehydration. And even that alone can further lead to what? Hypovolemic shock. It's 5. And then 6, there can be coma. Okay, so that is that for Addison's disease. Please, are you okay? Any question?
Please, the electrolyte, I think calcium is bad. Look, the calcium to be high. Potassium and calcium are always high.
Okay.
Electrolyte.
All right. Thanks for that addition. Thanks for addition. Please, any other question or contribution that we take? Yeah, moving on to Cushing syndrome, which is the opposite of the Addison. If you have any question to ask on Addison, you can bring it down. Let's talk about it before you go ahead. Or we are on the same page. Are you on the same page?
Yes, please, we are all on the same page.
All right. Is the understanding going on well? Please, are you understanding everything?
Yes, please, we are.
Okay. Very good. Okay. If that is so, I have some questions hide up at the end of the slides. Okay. So if you don't ask, I'll ask them later. All right. So let's talk about Cushing. So based on what we've discussed concerning Addison's disease, can someone just give us a summary of Cushing syndrome? Someone suggested for the example of Cushing syndrome.
Okay. Cushing syndrome. That one also it comes as a result of what? Chronic, like people who abuse of steroids. So so there's a problem that comes, or the electrolytes that you will experience is that you have high, everything is high. Sodium, no, most of the things are high. Sodium is high, sugar is high, BP is high, whilst the potassium and the calcium will be low. And they are expected to get what? Weight gain. Weight gain. So they have buffalo hump, puffy, moon-like face. And edema.
Okay.
Thank you.
All right. Very good. Anybody to also say something about Cushing syndrome based on
So
what has
to
been said?
add to that,
Just like she said,
so
no,
to add,
it's the overproduction of the steroids and glucocorticoids.
Okay. All right. Any other?
okay. Yeah, so we made mention of some signs and symptoms, and then one cardinal thing was the bronze hyperpigmentation. And then the explanation to that was because there's low production of the adrenal hormone. It causes more melanocytes to be produced. That is what will lead to the hyperpigmentation, dots in the skin. And so we should take note. And then there's
That is for Addison
hypertension.
disease.
Yes, Addison. I'm talking about.
Okay. Talking about Addison.
I think at this
Yes.
Cushing there's dry, like they have this stretch marks. It's a sign that somebody have abused steroids. Thank you.
Yeah, because steroids makes the skin very thickened. Okay, and when the skin becomes thickened, it begins to stretch. Okay, it begins to stretch, leading to this dry. Okay, so let's take note. All right. Okay, so let me ask, what is going to occur between okay, even someone has said it, the sodium and the potassium. Okay, someone has even said it. But can someone give us a mechanism? Why is there high sodium and low potassium here in the Cushing syndrome? The mechanism.
Okay, so then let me try. You were saying that aldosterone is an adrenal hormone, okay, and that is what it retains sodium and then excretes potassium. But then when there's problem here, instead of the adrenal hormone retaining the sodium, it rather excretes the sodium. And then, or when there are low levels of the adrenal hormone, the sodium is rather excreted. And when the sodium comes out, the potassium is rather retained. So that is what may also even lead to the salt cravings and all that. So I think that's my explanation for that.
Okay. But in the Cushing's, what is going to occur in the Cushing's?
High sodium, low potassium.
High sodium, low potassium. Because
Adrenal, the aldosterone level is high.
It's high. Okay, aldosterone is supposed to retain sodium and excrete potassium. But so because in Cushing's is very, very high, it will retain more of the sodium. Okay, and then also excrete more of the potassium. You are going to get severe hypokalemia, and then we are going to get what? A severe hypernatremia. Okay, very good. And then this patient is going to get hyperglycemia, hypertension, like those things are going to go high because there's more sodium. If there's more sodium, anywhere there's what? There is water. Water will also be retained, and this will increase the intravascular volume, and then your BP will go up. Okay, so that is the explanation. That is the linkage. Okay, between these three or between these things. Okay. Now, before we begin, I think I omitted something. Please, when you are giving steroids, steroids should always be given with food. So, if a patient have Addison's disease and the doctor prescribe like hydrocortisone, okay, let me say, or glucocortisone, okay, for this patient to replace the steroids, it should always be taken with food because steroids can cause gastrointestinal bleeding. You shouldn't take steroids on an empty stomach. Steroids should always be taken with what? With food to prevent intestinal bleeding because steroids can cause bleeding. Okay. All right. So Cushing syndrome is a rare endocrine disorder caused by excess cortisol production leading to various systemic complications. I'll be fast over here because it is just the opposite of Addison's disease. Okay. So here it is just that there is excess production of cortisols. Okay. Excess production of cortisol. We have types. I think we have two types. Okay. We have the endogenous Cushing's, and this one endo. So when we say endo, it means within or internal factors. So when there's a cancer of the pituitary gland or there's adrenal gland tumors, this will cause the proliferation of abnormal cells. Okay. And then, when there's an increase in these abnormal cells try to mimic the cells of the Cushing's gland, or let me say the adrenal gland. Okay. In cancers of the adrenal gland, there will be proliferation of cells. And when these cells begins to proliferate, they try to mimic the effects of the adrenal hormones or adrenal gland, and then they begin to increase more of the cortisols, leading to what? Cushing syndrome. Then two, we have exogenous Cushing. These ones are caused by external factors like long-term corticosteroid use. So even if you have Addison's disease, at the long run, you can get Cushing syndrome. Because if you have Addison's, we say you have to take what do you call it? You have to take cortisols, or you have to take steroids for life. You get it? If you have Addison's disease, we say take steroids for life. So if you take steroids for life, that long-term use can now push you to getting Cushing syndrome, whereby there will be too much steroids or excess cortisols in your body. Okay. All right.
So I want to say something. I want to find out something. Can we also say that somebody who is having a Cushing syndrome is on the steroids and stops the steroid abruptly can also get Addison's disease? Is it possible?
You have Cushing syndrome.
Yes, please. And you have stopped that. You have just stopped the corticosteroids abruptly without tapering it down. Can we also say because of somebody getting Addison's disease?
Yeah, once you stop taking this abruptly, you actually get Addisonian crisis. Okay, I'm going to get Addisonian crisis. That is what I'm going to usually experience when you stop taking steroids abruptly. Okay, that is it. Okay, all right, good. So we have pituitary adenoma, adrenal gland tumors. All these are cancers. The adenoma tumor, they are all cancers that occurs in the pituitary gland. And when this occurs, there is proliferation of what? Abnormal cells. These abnormal cells begin to mimic that of the normal cells and begin to produce more cortisols, leading to Cushing syndrome. Okay. All right. And the family type, that is the family type, that is what you call it, the hereditary aspect. Okay. So if a family member have it, likely they're going to go, but that one is very, very rare. Okay. Then therefore, we have the iatrogenic causes, that is by medical treatment. Get it? By medical treatment. That is, if you are taking too much steroids, you can get the Cushing syndrome. Okay. Good. Now we have some symptoms here. We have weight gain, moon face, buffalo hump, purple stripe, okay, and then hirsutism. All these are caused by too much cortisols. Okay. When there's too much cortisols, there is a buildup of fat. Let's not forget, okay, anytime your cortisol levels increases, it contributes to the accumulation and buildup of fat. When there's too much fat, you increase weight, okay, or you begin to swell up, like you begin to become fat. Okay. So that is why I'm going to get the moon face, the buffalo hump. Okay. So all these things are the reasons why you are getting the moon face and the buffalo hump. Now, the purple stripe or the stretch marks, when you get too much steroids in your blood or too much cortisol, your skin begins to become thickened. Okay, it becomes very, very thick. And then once it becomes very, very thick, it can cause a stretching of your skin. Okay, and then when the skin begins to stretch, you now get the purple stripe, like the stretch marks. That is why you begin to get stretch marks. Okay, there can be weight gain. Okay, there can be weight gain because you are increasing in fat. So because there is weight gain, you are going to get what? Because there is too much fat accumulation, you can get weight gain. Okay, very good. Then we have hirsutism, excessive hair growth. So excess cortisol can stimulate the production of androgens. Especially for a male. Okay, when you have too much excess, androgen is also part of the adrenal hormones. You get it? There's too much secretion of androgens. And when there's androgens excess, you are going to get too much testosterone. And testosterone helps with what? Hair growth. Then it's going to increase your hair growth. Okay, and then that's going to be hirsutism. Okay. And then even in females, automatically, when there's too much cortisols can increase a lot of production of hairs on your skin. Okay. All right. There can be acne, and then there can be hypertension here, diabetes mellitus, osteoporosis. Okay. All these can be signs and symptoms of what? Of Cushing syndrome. There's going to be mood changes. Of course, depression is going to set in. Okay. There's going to be anxiety, hypokalemia. I said it, and then bleeding. I said it earlier on that steroids can cause bleeding, especially gastrointestinal bleeding. Okay. So all this is going to be okay. And then they are going to have a poor wound healing.
No. It's late. I'm going to use it.
They are going to have what? A poor wound healing because of what? Because of the glucose level. There's going to be what? A poor wound healing. Okay. Very good. So please, these are some of the signs and symptoms of what? Of Cushing syndrome. Let's not forget, okay? These are some of the signs and symptoms of Cushing. Very good. All right. So the diagnostic test, we do what we call the 24-hour urine-free cortisol test. Okay. 24-hour urine-free cortisol test. Let's not forget. So this one, you will just take a sample of your urine for 24 hours. Okay. And then in all of them, you'll be testing for your cortisol levels. So if you test for your cortisol levels and they are very, very high, then we say that you are having what? Cushing syndrome. So it's like the 24, we have what we call the serial collection. I'm sure you all know that, the urine serial collection. It is similar to this one. So you do the 24-hour urine collection, okay? And then in all of them, you'll be testing the presence of cortisols. You get it? The presence of free cortisol. So if when we test and then the levels are very, very high, okay, the levels are very, very high, we can conclude that the patient have what? Cushing syndrome. You get it? We can conclude that the patient have Cushing syndrome. Okay. All right. Then the midnight cortisol levels test. Again, it's the same idea. Okay, it's the same idea. At night, your cortisol level goes down. Like 6 p.m., 7 p.m., 8 p.m. Your cortisol levels goes down. So in the evening, when we take your blood sample to check your cortisol level, it should be down. Okay, it shouldn't be high. It should be down. So if in the evening we take your blood sample to check the cortisol level, and then you are getting high levels of the cortisols, then it means that you have Cushing syndrome. Okay, because at night you have to get a low cortisol level at night. But if at night you are getting high cortisol levels, then it means you have what? Cushing syndrome. So we do the midnight cortisol levels. We do the imaging studies, MRI, CT scan, to visualize what? To visualize your adrenal gland very well. And then we can do the adenocorticotrophic stimulating hormone test, okay? Thyroid hormone stimulation test. It's the same thing that I said in the Addison's disease, okay? This one too is the same thing. We are going to take your blood sample and then check your cortisol level as a baseline. After that, we will give you an artificial adenocorticotrophic hormone. We give an artificial one through IV. When we give it to you, after 30 minutes time, we have to check that your levels are either high or low. If you check and the levels are high after 30 minutes time, then it means that the patient have what? Cushing syndrome. Okay. Very good. Now, these are some of the drugs that we give in what? We give in Cushing syndrome to help with the situation. We give what we call the ketoconazole, okay? The ketoconazole. And this is an antifungal that inhibits what? Cortisol's production. You get it? It's an antifungal that inhibits what? Cortisol production. The rest of the drugs, the etomidate, okay, and then metyrapone, okay, all these drugs are given to prevent the production of what? Of adrenal hormones, the excess production. They are given to just inhibit the production of the adrenal hormones, okay. So when you give these drugs, the patient will not produce more of the adrenal hormones, and the Cushing syndrome is going to be well controlled. Okay. All right. Now we can do what we call the transsphenoidal hypophyseectomy. Okay. We can do what we call the transsphenoidal hypophyseectomy. That is the removal of the pituitary gland. I think we have been saying it here over and over. The pituitary gland is the master gland. Okay. So if something happens to the pituitary gland, it can occur to the rest of the gland. Okay. So if we realize that the cause of the Cushing syndrome is cancer of the pituitary gland, then we have to go and do what? A removal of the gland. And that is called the transsphenoidal hypophyseectomy, to take away the pituitary gland. Now, if this surgery is done, it can affect plenty organs. It can affect the adrenal, the thyroid, it can even cause DI because now the pituitary gland has been taken off. Then two, you can do the adrenalectomy. That is the adrenal gland. Okay. If you are realizing that there's too much production of adrenal hormones and then our management is not really solving the situation, then we have to do what? We have to increase, or we have to do surgical procedure whereby we take off the adrenal gland. Okay. So that one too is another thing we should take note of. Get it? Right. So that is it. What again? As nursing interventions, okay. Nursing intervention. So you have to engage in stress management, regular exercise. But here we are restricting salt and water because there is too much sodium retention. Okay, there is too much sodium retention, so you must restrict salt and water over here. Then, because there is hypokalemia, what do? You have to give potassium rich food and even give potassium chloride. Okay, because here there is low there's low potassium level, so you must give potassium rich foods and then give potassium chloride. Then you also observe for cardiac arrhythmias because this patient can do what? Can get what you call hypokalemia and can lead to cardiac arrhythmia. So you must observe for cardiac arrhythmias. You initiate cardiac monitoring. Okay? Initiate cardiac monitoring. You must monitor their patient's BP level very, very well because there's going to be hypertension as well. There's too much sodium, then this has caused an increase in the patient's intravascular volume, leading to high blood pressure. So what do? You must monitor their patient's BP very well. You must monitor patient's glucose level as well because there's what? There's hyperglycemia. And then lastly, you must give them a balanced diet. Give them a balanced diet. Okay. All right. Good. So there are some complications over here. You are going to get cardiovascular disease and then even stroke. Okay. There's hypertension. So if the hypertension or the BP is not well controlled, if the BP is not well controlled, what is going to occur? There's going to be severe hypertension. It can even lead to hypertensive crisis and can cause stroke to set in. Okay. It can cause stroke to set in. So all these are complications of what? Of Cushing syndrome. We can get diabetes mellitus. You get it? Because there's excess glucogenesis. I said that if there's too much cortisol production, there will be too much glucogenesis. Glucogenesis can increase your glucose level. That can lead to diabetes mellitus. So that can be a contributing factor. Okay. 5, we have osteoporosis. So anytime there's too much cortisols, cortisols can lead to bone loss and it can lead to osteoporosis. You get it? Cortisols has a way of also inhibiting osteoblasts as well. You get it? So the cells that are responsible for bone formation, cortisols can inhibit them and it can cause a weakening of your bone, leading to osteoporosis. And also, cortisols sometimes interfere with calcium and vitamin D metabolism. Okay. And if you have low calcium and then low vitamin D, you are going to get osteoporosis. 6, there can be infections. I said it, that steroids reduces the function of your immune system. I said it right. Anytime there is low steroids, there's going to be reduction of the immune system function. And that can lead to what? Infection. So let's not forget, okay, that can lead to infections as well. And then lastly, you can get what? Bleeding. Okay, you can get bleeding as a complication of Cushing syndrome. You can get bleeding as a complication of Cushing syndrome. So because there is bleeding, okay, let me try and go. When there's too much cortisol, it impairs coagulation cascade and it leads to prolonged bleeding time. So let's not forget, anytime there's too much cortisol, it impairs the coagulation cascade. The time it takes for your blood to clot will be impaired, and this will increase the bleeding time, leading to bleeding. And also, cortisol can cause low platelet count, like it can cause thrombocytopenia. Okay, cortisols can cause thrombocytopenia or Cushing syndrome, or too much steroids can cause thrombocytopenia, whereby there will be low platelet count, and that one can increase your risk for bleeding. So on your NCLEX, what are some of the areas we should be expecting? On bleeding, we should be expecting bleeding precautions, okay? Because cortisols or Cushing syndrome can cause bleeding. So 1, the patient should not engage in what? Should not engage in contact sports. Contact sports like basketball, like football, whereby you can hit someone. When a patient does these things, can cause bleeding. So they must engage in a non-contact sports. They must engage in it, like swimming. For swimming, hardly will you hit someone. So they must engage in contact sports, okay, like swimming, to prevent bleeding. They shouldn't be taking, too much anticoagulants, because their coagulation cascade has been affected. The time it takes for their blood to clot has been affected. So they shouldn't be taking too much anticoagulant, okay, or should be taking anticoagulant so that they don't bleed. Okay. Under osteoporosis, we can get questions under 4 risk precautions, because too much cortisols and steroids affect the way the bone forms. Okay, so you can get osteoporosis, which you can get questions under what? Under 4 risk precautions. Under 4 risk precautions, you must assess the patient's risk for falls. You must raise side views. You must put a non-skid source on the patient. There must be adequate lighting, okay, in the patient's room. All these are things that we should ensure they are being done to prevent falls in a patient. Okay, very good. So that is it. Okay, that is it. Or these are things that we should do when a patient is undergoing Cushing syndrome. So that is it for Addison's and then Cushing syndrome. Any question to ask, please? Hello, my people. Sister Mimi, Sister Mimi's voice.
Everything is okay. Let's move.
He said,
Everything is fine. You can move.
Please, we have some questions in the chat box.
Oh, okay. Some questions in the chat box. Please, after adrenalectomy. Okay, let me read this first. Please, do we have something like Cushing's triad? Yes, we have something like Cushing's triad. But who can tell me where that Cushing's triad falls under which condition?
ICP.
Okay. ICP. Okay, that one is intracranial pressures, not really under Cushing's syndrome. Okay, all right, ICP. Yes. Please, after adrenalectomy, is the patient going to take steroids for life? Yes. Okay. Yes. If a patient undergoes surgery whereby the adrenal gland has been taken, he must take adrenal, artificial adrenal hormone for life, because the hormone to produce is no longer there. Okay. It's very, very important. Very, very important. You get it. Very, very important. All right. Any other question?
Then, Bosaki, after adrenalectomy, meaning the patient is going back to Addison.
Exactly. Because the gland to produce the hormone is no longer there. So you are going to Addison Street. Okay. It is like a patient with SIADH. Okay. Whereby there's more production of antidiuretic hormone. Then we do removal of the pituitary gland. Once you finish the procedure, you are going straight to EI. The gland to produce the hormone is no longer there. So you are going straight to DI. Okay. All right. That is it.
Okay, please.
Any,
The slide
yeah.
for the drugs and surgery. And
This
then
one.
the drugs.
The drug, we have the ketoconazole, the metharopone, and the etomidate. Okay, you know these drugs are usually the ones they give in Cushing syndrome. Okay. All right. Are we okay? Can we move ahead for some questions before we close? Hello, class.
Let's go.
Yes,
Are
sir.
we okay? All right, good. So now let's do some questions and then close. Okay. And the Addisons and the Cushings. Okay, so someone should kindly read for us and let's answer. Or who volunteer read for us?
Nurse Ron is assessing a client with possible Cushing syndrome. In a client with Cushing syndrome, the nurse would expect to find A, hypotension, B, thick, coarse skin, C, deposits of adipose tissue in the trunk and also cervical area, D, weight gain in arms and legs.
Okay, what are you going for?
B, C, and D.
Truncal obesity.
It is just one answer. It's not SATA.
Is C.
C.
It's C, yeah, C.
Deposit of adipose tissue in trunk and okay. So that is truncal obesity and then buffalo hump, right?
Yes, please.
Okay. All right, let's read. Now you see why the D is not correct. Okay. Yeah, let's see.
Disqualified.
Adipose or deposit of adipose tissue in the trunk and also cervical area. Okay. Very good. So when there is, because of changes in the fat distribution, okay, you know, I said it, that when you have Cushing syndrome, there's too much what production of fat. Okay. So let's not forget. So because there is changes in fat distribution, adipose tissue accumulates in the trunk, face, and then those cervical areas. So this one leads to the buffalo hump and the moon face and the rest. Hypertension is caused by fluid retention. Skin becomes thin and bruises easily because of the loss of collagen. Okay. And the muscle wasting causes muscle atrophy and thin extremities. So usually they don't get weight gain in their arms and legs in Cushing's. Okay. You know, in Cushing syndrome, it's like their weight is around their face, their trunk and their back. Okay. But then their extremities become very, very thin. And then there's muscle atrophy as well. Okay. All right. Can someone read and let's answer this one?
In a 29-year-old female client who is being successfully treated for Cushing syndrome, Nurse Lizette would will expect a decline in A, serum glucose level, B, hair loss, C, bone mineralization, D, menstrual flow.
Hair loss. Oh.
Cushing syndrome. Hey, do you have a loss in Cushing syndrome?
Oh, they have hirsutism.
Yes.
Hey, serum glucose level.
But the patient has been successfully treated with Cushing syndrome. Please
So
answer the
which one
question.
will decline? Expect a decline in the serum sugar level. Or
So let's put the answer.
Hyperglycemia. They have hyperglycemia in Cushing syndrome.
Yeah, I think it's D.
I think it's B.
I think it's A. They have hyperglycemia. So when they are treated, the glucose level will decline. It's A.
A. Okay. Why not B? Why is B not correct?
So
Then
because
C
the patient has already been treated.
tends to look like
So if you have the hair loss and you've been treated, you will not have hair loss again.
Okay.
But the person is having DM or a high glucose level. So when the person is treated, I will expect a decline in the glucose level.
Let's see if we are right. The answer is A. Hey, please, whose child is
Please,
making
someone's
noise?
child is disturbing and we can't hear.
Oh my God. Okay, so hyperglycemia, which develops from glucocorticoid excess, is a manifestation of Cushing syndrome. With successful treatment of the disorder, the glucose level will decline. Okay. Hypothyroidism is common in Cushing syndrome. Therefore, successful treatment lead to abnormal hair growth, also decline. Osteoporosis occurs in Cushing syndrome. Therefore, with successful treatment, bone mineralization will increase. Amenorrhea develops in Cushing syndrome. With successful treatment, the client experiences a cycle of menstrual flow, not a decline. Okay. So that is also that. Okay, which of the following nursing implications is most important in a client? Oh, please, can we mute that? Which of the following nursing implication is most important in a client being medicated for Addison's disease? Okay, which of the following nursing implications is most important in a client being medicated for Addison's disease? A. Administer oral forms of drug with food, minimize osteogenic effects. B. Monitor capillary blood glucose for hypoglycemia in diabetic clients. C. Ensure the client never abruptly discontinue the medication. D. Teach the client to consume a diet high in potassium, low in sodium, and high in protein.
C.
C. Ensure the client.
C. C.
Ensure the client.
Yeah,
no,
if
no.
they stop abruptly, it would lead to Addisonian crisis.
Okay. Okay. All right. Okay. Okay. So, but why not A? Administer oral forms of drug with food to minimize osteogenic effects. Why not A?
I think it's A because you mentioned that it should be taken with food because it can cause GIT bleeding.
But you know that in the Addisonian crisis, you manage with IVs instead of the orals. But I was even thinking of the B, monitor capillary blood glucose for
hypoglycemia, right?
diabetic clients.
So you see, A, B, and C are correct. Okay.
They look
Because
similar.
you have to give the food with oral medication to prevent the ulcer effect. Patient with Addison's disease get hypoglycemia, so you have to monitor for it. And then C, you have to also ensure the patient never abruptly discontinue the medication. But do you know, when you get questions like this on the NCLEX, what do you have to take note of? Let's go back to the
Most
question.
important.
Exactly. Most important. So priority. Okay. Priority. So because of that, you will settle for C because the Addisonian crisis is very, very severe. Okay. The Addisonian crisis is a life-threatening complication of Addison's disease. Okay. So the answer is C. Okay. Ensure the client to never discontinue the drug abruptly because of Addisonian crisis. So let's see the rationale. The primary medical treatment of Addison's disease is replacement of corticosteroids and then mineralocortisols, okay, accompanied by increased sodium in the diet. The client needs to know the importance of maintaining a diet high in sodium and low in potassium. Medication should never be discontinued abruptly because crisis can ensue. So let's not forget, you shouldn't discontinue the drug abruptly to prevent Addisonian crisis. Oral forms of the drugs are given with food in Cushing syndrome. So because of the most important, priority comes in here, okay, and then the C is our answer. Maybe we can do this last question. A client newly diagnosed with Addison's disease is given a written explanation of the teaching done by the primary nurse. Which of the following statements indicate that further teaching is necessary? So once you see further teaching is necessary, we are going for
wrong answer.
negative, exactly, negative option. A, I need to increase how much I drink each day. B, I need to weigh myself if I think I'm losing or gaining weight. C, I need to maintain a diet high in sodium and low in potassium. D, I need to take my medication each day. What are you going for? This is our last question.
A.
I need to increase how much I drink each day. Okay. A.
C.
D.
It's D. What it means further management, further
Is the one that is improper.
Because it's a wrong teaching, like wrong statement. So it's A.
Is it A?
Yes.
Are we going for A? Are we sure?
Further teaching, yeah. So the rest are right in the A is wrong.
Okay. Okay. I should weigh myself if I think I'm losing or gaining weight. Is that on the answer?
I need to weigh myself.
Don't you think it's B?
Yeah, it's B. Because if you think of any changes, you need to report, not to self-manage by weighing.
I need to weigh myself.
B. The answer is B. B. I need to weigh myself if I think I am losing or gaining weight. No. Because I need to increase how much. You see, with Addison's disease, we have hypotension. So this I need to increase how much I drink each day. There's no problem with it.
What are they drinking? What is it
Because
drinking?
of hyponatremia.
All
Hello,
right,
boss.
so
Hello.
Yes.
yeah, I can speak.
Oh,
One after
please,
the
it's
other.
like some other people have answers. If we could be raising our hands, it would be better.
Yes. Okay. That one is better. So please, can you talk? Can you talk?
Yes, please. I'll go for B because in Addison's, there's no weight gain. So I'll go for B.
Okay.
Thank you.
That is better. Okay. So now the answer is between A and B.
Okay,
I'm going for A.
Because B, I need to weigh myself if I think I am losing or gaining weight. It's good. When you think you are losing weight or gaining weight, you have to weigh yourself to see, say, who gain and now who loses. So I think that one is positive, it's not negative. So
Okay,
I think
all right. Let's see the next slide.
Let me also come in.
Okay, come in.
Because of the hyponatremia, it means you'll be having
you are losing water.
If you take more of the water, you are going to dilute it. You end up diluting and worsening the hyponatremia because of a insufficiency of the aldosterone.
But in Addison, in Cushing syndrome, in Addison, okay, I mean, you're talking about, okay, all right, I understand where you're coming from. So, okay, now, anyway, let's see the rationale. The next slide, okay. Let's see the rationale on the next slide. Okay, let's see. The answer is B. I need to weigh myself if I think I am losing or gaining weight. So now let's see the rationale. The client is at risk for ineffective therapeutic regimen management. Okay. Clients with Addison's disease must learn to provide lifelong self-care that involve varied components, medications, diet, recognizing and responding to stress. Changes in lifestyle are difficult to maintain permanent. The client needs to take the medication on a daily basis. The client needs to perform daily weights to monitor for signs of dehydration. The client needs to maintain a diet high in sodium and low in potassium, and also maintain an increased fluid intake. Okay, an increased fluid intake. So please, I'm sure we are getting it. Why the A was not selected as the right answer? Because the patient have to increase their fluid intake. But then if you pick I need to weigh myself if I think I am losing or gaining weight. Okay. You don't have to think. The weight should be daily. You have to perform the weight daily. The weight manage is daily. You don't have to think when you are losing weight or gaining before you have to weigh yourself. In Addison's disease, you are losing the weight. So the weight is straight daily manage, straight daily measurement. Okay. It is straight daily measurement. So you don't have to wait to think whether we are losing weight or gaining before you do the weight checking. You get it? That is why the B was the right answer and then the A was wrong. Okay. All right. So this brings us to the end of today's class.